You're just a nurse." That's what Linda Harrington said on August 23, 2024 at 4:15 p.m. in her executive office at Riverside Regional Hospital, waving her hand dismissively when I tried to explain why the patient billing codes I was being instructed to document didn't match the actual care provided, her tone making it clear that hospital administrators with MBAs made decisions about billing and revenue while nurses with bedside experience were expected to follow orders without questioning the financial implications of documenting procedures that never occurred. The afternoon sun through her window illuminated the framed awards on her walls: Healthcare Administrator of the Year 2022, Excellence in Hospital Financial Management, Regional Leadership Recognition, while I stood holding a folder containing 6 months of documentation showing patterns of upcoding, unbundling, and billing for services not rendered that I'd compiled because I understood that Medicare fraud wasn't just an administrative problem, it was patient care fraud that affected treatment decisions and violated the trust that patients placed in medical professionals. I'd been a registered nurse at Riverside Regional Hospital for 11 years, 7 months, and 23 days, working primarily in the medical surgical unit where I provided direct patient care, documented treatments and procedures, and entered billing codes that were supposed to accurately reflect the care patients received, and Linda, who'd been hired as Chief Operating Officer 14 months earlier from a corporate hospital chain known for aggressive revenue optimization, had decided that my concerns about billing accuracy were evidence that I didn't understand healthcare economics rather than evidence that I understood both patient care and Medicare regulations better than administrators who'd never worked at a patient's bedside. I'm Catherine Walsh, and I stood in that office knowing exactly what 42 U.S.C. Section 1327b said about healthcare fraud, that knowingly and willfully submitting false claims to Medicare could result in criminal penalties up to 5 years imprisonment and civil penalties of up to 3 times the amount fraudulently claimed. And knowing that the documentation I'd been compiling for 6 months included specific examples of procedures coded for billing that I'd personally witnessed had not been performed, services billed at higher complexity levels than actually provided, and a systematic pattern of instructing nursing staff to document care in ways that maximized reimbursement rather than accurately reflected treatment. 11 years, 7 months, and 23 days of providing patient care according to medical necessity rather than billing optimization, documenting treatments accurately rather than strategically, and understanding that Medicare billing codes existed to ensure the government paid for actual services provided rather than services that administrators wished had been provided to maximize revenue. And Linda had decided that my insistence on accurate documentation meant I was just a nurse who didn't understand the business realities of hospital operations. I wasn't the chief financial officer who prepared revenue reports and signed off on billing practices, or the chief medical officer who set clinical protocols and reviewed treatment decisions. I drove a 2016 Honda Accord with 143,267 miles and a back seat containing medical reference books and Medicare billing guidelines I reviewed to ensure the codes I entered actually matched the procedures documented, because accurate billing meant understanding both the clinical care provided and the regulatory requirements for coding that care. I lived in a 680-square-foot apartment with a home office containing printed copies of Medicare billing regulations, patient care documentation I'd anonymized and retained for reference, and detailed logs of discrepancies I'd identified between actual care provided and billing codes I'd been instructed to enter, documentation I maintained because I'd learned early in my nursing career that when billing practices conflict with patient care reality, having detailed records protects both patients and providers from fraud liability. I was methodical about documentation, careful about accuracy, and protective of patient care integrity, and apparently Linda thought these characteristics made me just a nurse, rather than the person whose understanding of both clinical care and billing regulations is the only thing preventing this hospital from committing systematic Medicare fraud. I joined Riverside Regional Hospital in January 2013 as a registered nurse after graduating with my BSN and passing my NCLEX examination. Riverside was a 340-bed community hospital providing general medical, surgical, emergency, and specialty care services to approximately 185,000 residents in rural Indiana. The hospital employed 890 staff members including 240 nurses, and generated approximately $180 million in annual revenue, with Medicare patients representing roughly 48% of total patient volume. My role in the medical surgical unit involved providing direct patient care, administering medications, monitoring patient conditions, documenting treatments and procedures, coordinating with physicians and specialists, and entering billing codes for nursing procedures and care coordination activities. Accurate billing code entry was considered part of nursing responsibilities because nurses were the staff members who directly witnessed and provided the care being billed. The billing system at Riverside was designed so that nurses documented care in the electronic health record system, and the system automatically generated billing codes based on documented procedures and treatments. However, certain procedures required manual code entry, and nurses were expected to select appropriate billing codes that matched the complexity and nature of care provided. For the first 10 years of my career at Riverside, billing practices were straightforward. We documented care accurately, selected codes that matched what we actually did, and billing staff in the revenue cycle department handled claim submission. The emphasis was on accurate documentation that reflected genuine patient care. This changed in July 2023 when Linda Harrington was hired as Chief Operating Officer. Linda came from MedCorp Health Systems, a large for-profit hospital chain known for aggressive revenue cycle management and optimization strategies that maximized reimbursement from government and private payers. Linda's mandate from Riverside's board was to improve the hospital's financial performance. Riverside had been struggling with thin margins due to increasing costs, declining reimbursement rates, and competition from larger health systems. The board wanted leadership that could improve revenue without reducing services or laying off staff. Linda's approach focused on revenue cycle optimization, ensuring that Riverside captured maximum reimbursement for every patient encounter. This involved reviewing billing practices, training staff on appropriate code selection, and implementing monitoring systems to track whether staff were using billing codes that maximized revenue. In September 2023, Linda's team conducted training sessions for nursing staff about optimal billing documentation. The training emphasized that nurses should select billing codes that reflected the full complexity of care provided and that we should document care in ways that supported higher-level coding. The trainer, a revenue cycle consultant from an external firm, presented examples of how to document patient care to justify higher complexity billing codes. If you spend time coordinating with multiple specialties, document that coordination with specific details about each communication. That supports care coordination billing at higher levels. If you provide patient education, document the specific topics, duration, and patient comprehension assessment. That supports educational service billing. If you assess a patient's condition, document all body systems reviewed even if only one system is the focus of concern. That supports higher complexity assessment billing. This guidance made me uncomfortable because it emphasized documenting to support billing rather than documenting to accurately reflect care. I raised this concern during the training. Isn't the priority to document what care was actually provided rather than documenting to maximize billing? I asked. The trainer smiled. We're not asking you to document care that didn't happen. We're asking you to comprehensively document all the care you actually provide. Many nurses underdocument their work, which means the hospital doesn't get reimbursed for valuable services. Better documentation means better reimbursement for work you're already doing. That explanation seemed reasonable in isolation. But over the following months, the pressure for better documentation evolved into explicit instructions to use billing codes that didn't match actual care. In November 2023, I was caring for a Medicare patient, Mr. Harrison, age 74. Who'd been admitted for pneumonia. He was receiving 4 antibiotics, respiratory therapy, and standard monitoring. On his 3rd hospital day, I documented his morning assessment, medication administration, and vital signs monitoring. When I went to finalize my shift documentation, I found that the system had pre-selected billing codes for complex care coordination and multi-system assessment that suggested I'd spent significant time coordinating with multiple specialists and had performed comprehensive assessments of multiple body systems. I hadn't coordinated with any specialists that day. Mr. Harrison's care was being managed by his primary hospitalist. And my assessment focused on his respiratory status, not multiple body systems. The pre-selected codes didn't match what I'd actually done. I changed the codes to accurately reflect the standard care I'd provided. The next day, I received an email from the revenue cycle manager asking why I'd downcoded Mr. Harrison's care when my documentation supported higher complexity billing. I responded, I didn't downcode. I selected codes that accurately matched the care I provided. Mr. Harrison received standard. Pneumonia treatment. I didn't perform multi-system assessments or complex care coordination. The revenue cycle manager replied, but you did assess his condition, coordinate his care, and monitor his progress. Those activities support the higher level codes. Please use the system-suggested codes unless there's a specific clinical reason they're inaccurate. This became a pattern. The electronic health record system began pre-selecting billing codes that were more complex than the care actually warranted, and revenue cycle staff pressured nurses to accept those codes rather than adjusting to accurate levels. By February 2024, I'd identified multiple concerning practices, upcoding procedures, billing for higher complexity versions of procedures than actually performed. Standard wound dressings billed as complex wound care. Basic patient education billed as comprehensive discharge planning. Routine assessments billed as multi-system evaluations. Unbundling services, billing separately for components that should be billed as a single bundled service. For example, billing separately for medication administration, patient monitoring, and care coordination that were part of a single treatment episode that should be billed as one code. Billing for services not rendered, documenting procedures in billing systems that never occurred. I discovered instances where respiratory therapy sessions were billed but the respiratory therapist's notes showed the sessions didn't happen. Physical therapy evaluations billed but PT documentation showed the patient declined the evaluation. Misrepresenting medical necessity, billing for procedures by documenting medical justifications that didn't reflect actual clinical assessment. Ordering tests not medically necessary to support billing for services that required those test results. I began documenting these discrepancies in detail. Each time I identified a billing code that didn't match actual care, I made notes, patient identifier, anonymized in my personal records, date, procedure billed, actual care provided, and the discrepancy between the two. By August 2024, I'd compiled documentation of 187 specific instances across 94 different Medicare patients where billing codes didn't accurately reflect care provided. I also documented the pressure from administration to use higher billing codes. I saved emails from revenue cycle staff instructing nurses to select specific codes. I printed policies from Linda's revenue optimization initiative that explicitly prioritized reimbursement over accuracy. I retained training materials that taught documentation strategies designed to support higher billing rather than accurate billing. In July 2024, the pressure intensified. Linda held a department meeting with nursing leadership where she presented data showing that Riverside's reimbursement per Medicare patient was lower than comparable hospitals in the region. "We're leaving money on the table," Linda said. "Other hospitals are getting reimbursed at higher rates for similar patients because their documentation supports appropriate coding levels. We need nursing staff to document more comprehensively so we can bill appropriately for the complex care we provide." The director of nursing, Patricia Chen, who'd been at Riverside for 18 years, raised a concern. "Are we asking nurses to document more comprehensively about care they're already providing, or are we asking them to change their documentation to support higher billing regardless of actual care complexity?" "We're asking for accurate, comprehensive documentation," Linda replied. "If that documentation supports higher reimbursement, that's appropriate. We're not asking anyone to document care that didn't happen." But the reality was different. The specific instructions nurses received from revenue cycle staff explicitly told us to select billing codes that maximized reimbursement even when lower-level codes more accurately reflected care provided. On August 23, 2024, I requested a meeting with Linda to discuss my concerns about billing practices. I brought my folder containing documentation of billing discrepancies, copies of emails pressuring staff to upcode, and examples of procedures billed for services not rendered. The meeting started at 4 p.m. I explained that I'd identified patterns of billing practices that appeared to violate Medicare regulations. I've documented 187 specific instances where billing codes don't match actual care provided, I said, showing her my log. These include upcoding, unbundling, and billing for services that documentation shows didn't occur. Medicare fraud regulations are clear that submitting false claims can result in criminal and civil penalties. I'm concerned that Riverside's current billing practices may constitute systematic Medicare fraud. Linda looked at my documentation briefly before pushing it back across her desk. Catherine, I appreciate your diligence. But you're misunderstanding what you're seeing. These aren't billing errors, these are examples of appropriate code selection based on comprehensive documentation. You're focused on individual tasks you personally performed, but Medicare billing codes reflect total care complexity, not individual nurse activities. When the system suggests a higher level code, that's based on algorithms that assess total care requirements. But I'm documenting the care I directly provided, I said. I know what procedures I performed. When the system bills for complex wound care but I provided standard dressing changes, that's not algorithm assessment, that's inaccurate billing. You're just a nurse, Linda said sharply. You're trained in patient care, not revenue cycle management. You don't understand the complexities of Medicare billing regulations, the nuances of code selection, or the business requirements of hospital financial management. What looks like inaccurate billing to you is appropriate revenue cycle optimization to people who actually understand healthcare finance. I sat there for approximately 10 seconds, processing the fact that she'd just dismissed 11 years of careful documentation work and regulatory knowledge as irrelevant because I was just a nurse. I understand Medicare billing regulations quite well, I said carefully. I've studied them specifically to ensure the codes I enter are accurate. The regulations are clear that billing must reflect services actually provided, not services that would maximize reimbursement. What you're calling revenue cycle optimization appears to meet the legal definition of healthcare fraud under 42 U.S.C. Section 1327b. Linda's expression hardened. Are you threatening this hospital with legal citations because we're asking you to do your job properly? I'm raising compliance concerns about billing practices that violate Medicare regulations. That's protected whistleblower activity under multiple federal statutes. What's protected is good faith reporting of actual violations, Linda replied. What you're doing is misinterpreting normal business practices as fraud because you don't understand healthcare finance. I suggest you focus on patient care and let qualified administrators handle billing. This meeting is over. I left Linda's office at 4:22 p.m., drove home in my Accord with 143,267 miles, and sat in my home office surrounded by 6 months of documentation proving that Riverside Regional Hospital was systematically billing Medicare for services not provided and upcoding procedures to maximize reimbursement. Now about 71% of you think I'm about to immediately call the Office of Inspector General hotline to report Medicare fraud as revenge for being called just a nurse, and you're wrong about the timing but right about where this ends. Subscribe right now, because what actually happens is that I first report the billing concerns through Riverside's internal compliance hotline as required by proper channels, and when that report is ignored and I start receiving retaliation for raising concerns, then I file a CATAM lawsuit under the False Claims Act, which allows private citizens to sue on behalf of the government for fraud, and my 6 months of detailed documentation becomes the evidence in a federal investigation that results in a $12 million settlement, criminal charges against Linda for healthcare fraud, and Medicare program exclusion for executives who thought, just a nurse, didn't understand billing regulations well enough to document systematic fraud. I reported the billing concerns through Riverside's internal compliance hotline on August 26, 2024. The hospital's compliance program had an anonymous reporting system specifically for staff to raise concerns about potential fraud, waste, or abuse without fear of retaliation. My report was detailed. I explained the patterns I documented: systematic upcoding, unbundling, billing for services not rendered, and administrative pressure on nursing staff to select codes that maximized reimbursement rather than accurately reflected care. I included specific examples with dates, patient identifiers, and billing codes. I referenced the Medicare regulations being violated. The compliance hotline acknowledged receipt of my report and stated that all reports would be investigated confidentially. 2 weeks later, I received a call from Human Resources requesting a meeting to discuss workplace concerns. The meeting was scheduled for September 12, 2024. I attended the meeting expecting to discuss my compliance report. Instead, HR Director James Morrison told me that my attitude and approach to billing documentation had been raised as a performance concern by my supervisor. Your recent interactions with revenue cycle staff have been described as uncooperative, James said. You've been resistant to guidance about appropriate code selection and have been questioning billing decisions that aren't within your scope of responsibilities. We need nurses who are team players and who focus on patient care rather than trying to manage billing operations. I raised compliance concerns through the proper channel, the compliance hotline, I said. I documented instances of billing codes that don't match actual care provided. That's not being uncooperative, that's identifying potential Medicare fraud. Your compliance report was reviewed, James replied. The investigation found no evidence of fraudulent billing. The practices you questioned are standard revenue cycle management. Your interpretation of those practices as fraud suggests you don't understand the complexity of healthcare billing. Who conducted the investigation? Our compliance department, in consultation with revenue cycle management. So the people implementing the billing practices I reported investigated whether those practices were fraudulent and concluded they weren't? James looked uncomfortable. The investigation was thorough and objective. And now I'm being called to HR for a performance concern about questioning those same billing practices. That's textbook retaliation for whistleblower activity. This is a performance conversation, not retaliation. We're asking you to focus on your job responsibilities and work cooperatively with revenue cycle staff. The meeting ended with a verbal warning that would be documented in my personnel file about uncooperative behavior and inappropriate questioning of administrative decisions. I left that meeting knowing that internal reporting had failed and that retaliation had begun. I contacted an attorney who specialized in False Claims Act cases. The False Claims Act allows private citizens, called relators, to file lawsuits on behalf of the federal government against entities that have defrauded government programs. In healthcare, this typically involves Medicare or Medicaid fraud. If the government recovers money based on the relator's lawsuit, the relator receives a percentage of the recovery, typically 15–30%, as a reward for exposing fraud. My attorney, Margaret Sullivan, reviewed my documentation carefully. This is strong evidence, Margaret said. You have specific examples of upcoded procedures, documented pressure to select higher billing codes, and patterns showing systematic rather than isolated errors. You also have evidence of retaliation after internal reporting, which strengthens the case. We should file a CATAM complaint. We filed the CATAM complaint under seal in the U.S. District Court for the Southern District of Indiana on September 25, 2024. The complaint alleged that Riverside Regional Hospital had submitted false claims to Medicare in violation of the False Claims Act, and that the systematic billing fraud had resulted in fraudulent claims totaling at least $12 million over 18 months. Under False Claims Act procedures, CATAM complaints are filed under seal while the Department of Justice investigates whether to intervene in the case. The seal period typically lasts several months while federal investigators review evidence and determine whether the government will join the lawsuit. During this period, I continued working at Riverside while federal investigators began their review. I didn't discuss the lawsuit with anyone except my attorney. I continued documenting billing discrepancies and adding to my evidence file. The retaliation escalated. In October 2024, my work schedule was changed to less desirable shifts. In November, I received a written warning for documentation deficiencies, claiming that my patient care notes were insufficiently detailed, which was ironic given that my documentation was more detailed than most nurses specifically because I was careful about accuracy. On December 3, 2024, I was called to another HR meeting and placed on administrative leave pending investigation of serious performance concerns. The suspension was paid, but it effectively removed me from patient care and from access to the electronic health record system where billing discrepancies would continue to be visible. This suspension turned out to be helpful for the federal investigation. Margaret filed a motion to lift the seal early due to employer retaliation, and federal investigators from the Department of Health and Human Services Office of Inspector General accelerated their review. On January 15, 2025, federal investigators executed a search warrant at Riverside Regional Hospital, seizing billing records, emails, and computer systems related to Medicare billing practices. The investigation was now public, and news coverage began reporting that Riverside was under federal investigation for potential Medicare fraud. The Department of Justice notified the court on February 7, 2025 that the United States would intervene in the False Claims Act case. This meant the federal government was joining my lawsuit against Riverside, bringing the full resources of the DOJ to pursue the fraud claims. Over the next 4 months, federal investigators interviewed dozens of Riverside staff members, reviewed thousands of billing records, and compared documentation of care provided against claims submitted to Medicare. My documentation became central to the investigation. The specific examples I'd compiled allowed investigators to identify patterns and expand their review to similar cases. The investigation confirmed the patterns I'd documented: systematic upcoding of routine procedures to higher complexity billing codes, unbundling of services that should have been billed as single codes, billing for services that documentation showed were not provided, administrative pressure on nursing staff to select billing codes that maximized reimbursement regardless of accuracy. In May 2025, the Department of Justice filed additional charges against Linda Harrington personally, alleging that she had knowingly and willfully directed the submission of false claims to Medicare. The charges included criminal healthcare fraud under 18 U.S.C. Section 1347, which carried potential prison time. Riverside's board responded by immediately terminating Linda and placing several other executives on administrative leave. The hospital hired an independent law firm to conduct internal investigations and began cooperating fully with federal authorities. On June 18, 2025, Riverside Regional Hospital entered into a settlement agreement with the United States. The hospital agreed to pay $12 million to resolve False Claims Act liability, implement extensive compliance reforms, and accept 5 years of corporate integrity monitoring by the Office of Inspector General. The hospital did not admit liability but acknowledged that certain billing practices had not conformed to Medicare requirements. Under the settlement, I received $2.4 million as my relator's share, 20% of the recovery. This was compensation for identifying and documenting the fraud, and for the retaliation I'd experienced after reporting concerns. Linda Harrington pleaded guilty to criminal healthcare fraud charges on July 22, 2025. She was sentenced to 18 months in federal prison and ordered to pay $340,000 in restitution. She was also excluded from participating in any federal healthcare programs for 10 years, effectively ending her career in hospital administration. I was reinstated at Riverside in August 2025 as Clinical Compliance Nurse Specialist, a newly created position reporting directly to the hospital's board-appointed compliance officer. The role paid $98,000 annually, a 47% increase from my staff nurse salary, and included authority to review billing practices, audit documentation, and report concerns directly to the board without going through administration. On August 15, 2025, I ran into Linda in the federal courthouse. She was there for a hearing related to her sentencing conditions. When she saw me in the hallway, she stopped. "Catherine, I heard you received quite a settlement from your whistleblower lawsuit." "I received compensation for identifying Medicare fraud that cost taxpayers millions of dollars," I replied. "The False Claims Act provides relator rewards specifically to encourage people with knowledge of fraud to report it." "You destroyed my career over billing practices that every hospital uses," Linda said bitterly. "Revenue cycle optimization is standard in healthcare. You made normal business practices sound like criminal fraud." "Revenue cycle optimization is standard," I agreed. "Medicare fraud is not standard. The difference is whether billing reflects actual care provided or whether billing is deliberately inflated to maximize reimbursement regardless of accuracy. You directed staff to upcode procedures, bill for services not rendered, and select codes based on revenue rather than clinical reality. That's not optimization, that's fraud." The Department of Justice agreed, which is why you pleaded guilty to criminal charges. You could have raised concerns differently. You could have worked within the system instead of going to federal investigators. I did raise concerns differently first. I reported through the internal compliance hotline as required. The hospital's investigation, conducted by the people implementing the fraudulent practices, found no violations. Then I was called to HR for performance concerns and placed on administrative leave. That's not working within the system, that's retaliation for reporting fraud. The False Claims Act exists specifically because internal reporting often fails when fraud is systematic and approved by leadership. The board overreacted, Linda said. and $12 million settlement and criminal charges over billing practices that saved the hospital from financial collapse. The hospital wasn't collapsing, I replied. It had tight margins like most community hospitals. You chose to address financial pressure with fraud rather than with legitimate efficiency improvements or service adjustments. You called me just a nurse when I questioned billing codes that didn't match actual care. You assumed that nurses didn't understand Medicare regulations well enough to identify fraud. That assumption was wrong. I understood the regulations. I documented violations. I reported properly. And when internal reporting failed and retaliation began, I filed a CATAM lawsuit that recovered $12 million in fraudulent claims. Linda looked at me with an expression somewhere between anger and resignation. You should have minded your own business. Patient care is a nursing business. Billing is an administrative business. Patient care is affected by billing, I said. When you bill Medicare for services not provided, you're committing fraud that ultimately harms all Medicare beneficiaries through increased costs and reduced trust in the system. When you pressure nurses to document inaccurately to support fraudulent billing, you're asking us to participate in fraud. That makes it our business. I'm a nurse. My business is patient care and professional integrity. Medicare fraud violates both. Linda walked away without responding. The following week, Riverside's new CEO, brought in by the board to rebuild the hospital's reputation and compliance culture, held an all-staff meeting to discuss the settlement and the changes being implemented. We failed in our responsibility to maintain billing integrity, the new CEO said. The settlement we've entered costs this hospital $12 million, damages our reputation, and requires years of compliance monitoring. More importantly, it betrayed the trust of our patients and the community. We're implementing comprehensive reforms to ensure this never happens again. The reforms included independent billing audits, compliance training for all staff, protections for employees who report concerns, and my new role as clinical compliance nurse specialist with direct board reporting authority. The new CEO publicly acknowledged my role. We owe significant gratitude to the healthcare professional who identified these problems and had the courage to report them despite facing retaliation. That individual's actions protected patients, taxpayers, and ultimately this hospital by forcing us to address practices that would have eventually resulted in far more serious consequences. Several of my nursing colleagues approached me privately after the meeting. I knew something was wrong with the billing pressure, one nurse said. But I didn't know how to document it or who to report to. I'm glad you did. Another nurse added, I was afraid to question the billing codes even when I knew they were wrong. I thought questioning the administration would get me fired. It almost did get me fired, I replied. But that's why whistleblower protections exist. And that's why the False Claims Act allows private citizens to sue on behalf of the government. Internal reporting doesn't always work when fraud is systematic and approved by leadership. Here's what they don't teach hospital administrators about nurses. We're not just bedside caregivers who don't understand finance. We're licensed professionals who understand both clinical care and the documentation requirements that support legitimate billing. We know what procedures we actually performed. We know when billing codes don't match reality. And we know that Medicare regulations exist to prevent the government from paying for services that weren't provided. Linda thought, just a nurse, meant someone focused on patient care who wouldn't understand or question billing practices. What it actually meant was someone who understood both patient care and billing regulations well enough to identify when billing codes systematically deviated from clinical reality, and who had the documentation skills to compile detailed evidence of fraud. The math is simple. Riverside Regional Hospital submitted approximately $12 million in fraudulent Medicare claims over 18 months based on billing practices that Linda implemented. Those practices involved upcoding, unbundling, and billing for services not rendered. I documented 187 specific examples across 94 patients, created detailed logs of billing discrepancies, and saved emails showing administrative pressure to use inaccurate codes. When internal reporting failed and retaliation began, I filed a CATAM lawsuit. The Department of Justice investigated, intervened in the case, and recovered $12 million plus criminal prosecution of the executive who thought nurses didn't understand billing well enough to identify fraud. You want to tell nurses they're just nurses who don't understand healthcare finance. Go ahead. But remember that nurses document every procedure we perform, enter many of the billing codes, and are required by professional licensing to maintain accurate records. When you pressure nurses to select billing codes that don't match actual care, you're asking us to participate in fraud. Some of us understand that, document it, and report it through proper channels. And when we do, the False Claims Act allows us to sue on behalf of the government and receive compensation for exposing fraud. Linda called me just a nurse while implementing systematic Medicare fraud. Federal prosecutors called my documentation detailed evidence of criminal healthcare fraud while charging her with felonies. The Department of Justice called me a relator under the False Claims Act while awarding me $2.4 million for identifying $12 million in fraudulent claims. Riverside's board called me clinical compliance nurse specialist while implementing the oversight systems that should have prevented the fraud in the first place. I kept my accord with 143,267 miles. I kept my medical reference books and Medicare billing guidelines. I kept the practice of documenting accurately because professional nursing standards require accurate documentation regardless of whether it supports revenue optimization or exposes fraud. Linda is serving 18 months in federal prison, learning that revenue cycle optimization has legal boundaries and that crossing those boundaries into fraud carries criminal penalties. Riverside paid $12 million to resolve False Claims Act liability and implemented 5 years of compliance monitoring. And I'm working in a new role that gives nurses authority to question billing practices without being told we're just nurses who don't understand healthcare finance. Just a nurse. Just enough to understand Medicare regulations. Just enough to document 187 instances of fraud. Just enough to identify systematic billing violations. Just enough to report properly through internal and external channels. Just enough to file a successful False Claims Act lawsuit. Just enough to end a career built on assumptions that bedside nurses don't understand billing regulations well enough to recognize fraud when we see it. Sometimes the person, just documenting patient care, is the only person in the hospital creating accurate permanent records of what care was actually provided versus what care was billed. And sometimes, just a nurse knows more about both patient care and Medicare billing regulations than hospital administrators who think revenue optimization means billing for services that weren't rendered. 11 years of providing patient care and documenting treatments accurately. 6 months of compiling evidence of systematic fraud. 1 CATAM lawsuit that recovered $12 million. And 1 hospital administrator learned in federal prison that dismissing nurses as just nurses is expensive when those nurses understand fraud better than administrators understand compliance.